Now we're going to look a little bit at implementation, discuss the implementation phase. Our panelists will share what the onboarding of a new application and the change process look like at their organization. Our first question is, what was your rollout strategy and some of the hurdles you had to overcome? Christy, I'll ask you to go first for UPMC.
Okay. Our rollout strategy was big bang. So we went all sites, all adult units that basically had the ability to care for a patient on an insulin drip across our 7 campuses went live at the same time. And it was a really big undertaking. It was a lot of end users, a lot of patient populations, and, you know, as I've said, a lot of stakeholders that we needed to get buy-in and, you know, share decision-making and to agree on things. So one of those hurdles was looking at our order sets. Our order sets needed changed across the board. And really, we made a decision to make it impossible to order an adult insulin drip in these areas without using EndoTool. But that required a lot of discussions with a lot of stakeholders, like our specialties between, you know, spanning adult, women's, and cardiac surgery. So I think that was probably one of the biggest hurdles to get over and work through those details for a smooth rollout.
That knowing how large your facility is, that big bang took a lot of effort and just concerted, diligent approach from you all to make that successful. Megan, what was the rollout strategy at HCA?
At HCA, we started with one hospital, which was here at Centennial in the TriStar division. So, you know, we wanted to trial it per se here and kind of perfect it before, or not perfect it, but try to make improvements before we went anywhere else. So we went live in all adult ICUs, medical, surgical, neuro, our cardiac ICU, but not in our cardiovascular surgery unit. So that one actually did not go live until about a year ago. They use IV insulin more than any unit in the hospital. So they were actually more well-versed on the old system we had and felt comfortable doing what they were doing. And, you know, we had some pushback initially on implementing this in that patient population. And so we went live in all other ICUs, had good data. And so we're able to show that to them and, you know, now are live across the board here at Centennial, and then have expanded over to one of our other sister hospitals in TriStar. So some of the hurdles we went through like that were, as I mentioned, some physician buy-in and trusting a software and that sort of thing. And then also just nursing, you know, with what to expect and the timeliness of it. You know, we obviously want timely IQ checks, but that can vary a little bit when it's on paper. And so when it's coming at you through technology, you know, that's something that, you know, they were having to work through of how they, you know, would stay on time, and it helped improve our quality for sure. So as mentioned by Christy, you know, changing our protocols and that sort of thing was something we had to do, and we also tried to make it difficult to order it outside. And so we had a lot of success with that as a glucose management team being here and able to help assist with that.
Thank you, Megan. It's interesting to hear that you know, rolled it out in a staged sort of approach, and then you had the data to help support those other units and sites coming on board. Jennifer, how did it look at Wake Forest?
Yes, the approach at Atrium Health Wake Forest Baptist is definitely more along the lines of what Megan said with HCA, and the approach was to start small. 2 adult patient care areas at the Academic Medical Center were selected, a cardiovascular intensive care unit and an intermediate care unit, which is like a step-down unit from the ICU. These units were selected based on metrics regarding glycemic management, as well as they had a high utilization of insulin drips. Intermediate care was also selected because most patients with DKA were bedded on that unit. We continued to devise a plan for where to implement the tool next. once again using data as well as expressed interest from leaders in those patient care areas. And to be very honest, the success we were having with patients on EndoTool was assisting in the request to roll the tool out to other areas. I just recently added another campus in ICUs in that setting as well, so really glad to keep rolling it out. We did have a few hurdles that our health system had to overcome prior to implementation. One such hurdle was the need to ensure that, just like everyone else has said so far, to align protocols, especially around hypoglycemia and insulin management. One particular thing that was interesting for our health system, we had preferentially used dextrose 10% for hypoglycemia because of just some ongoing shortages with being able to get D50. And EndoTool for adults does preferentially use D50 for hypoglycemic management. And so we had to also make that change ahead of the EndoTool implementation, working with our pharmacy team to adjust inventories and to ensure that our automated dispensing cabinets were set up correctly. So that was just another change that we had needed to make, but EndoTool helped us make it as well. Another hurdle was the completion of nursing education prior to go live. Our implementation was in early 2022, which was still a very challenging time related to COVID and taking care of patients. So it was challenging for nurses to be able to get away from their patient assignments to complete online learning, but we knew that it was instrumental in order to be able to go live. So our nurse leaders were very helpful in working with nurses to ensure that their education was completed. Also, prescriber education and awareness was a hurdle that we continue to work through even today as we continue to roll out EndoTool.
And Spring, I would add, I've heard all of the panelists mention the use of data, and there's often a lot of skepticism amongst physicians to use this software such as this. They feel that the current protocols are sufficient and doing a great job. Why should we do something different? But when you can look at your own hospital's hypoglycemia rate and compare that to what EndoTool offers, that tends to give a lot more reassurance to the providers and allow them to be accepting of it. So there is often a lot of skepticism amongst physicians in the beginning.
Thank you, Dr. Paul, and thank you all for sharing. It's really cool to hear how very different the approach can be from that big bang all the way to just the one pilot unit and then slowly moving out. And yes, data plays a big part. I also heard a lot of hurdles about just standardizing, how even within the same healthcare system, there is a lot of variables that then have to come together into a more standardized approach. So the question we would all love to know next is, looking back, what would you pivot or change in your approach and why? And Megan, I'll have you go first.
Well, I think, you know, our system was a little bit different in that we did already have our glucose management team established. And so I think having us as nurse practitioners really just available made us successful. We also are the ones ordering the insulin drip. And so we were already well versed in what the patient needed and how to order it and that sort of thing. And so I think, you know, from our standpoint, it went really well because we had a lot of control over it. But just really standing by our ICU teams and, you know, we're obviously not here 24 hours a day. So really getting them comfortable with ordering it and even nursing what to expect. There's a lot of steps in the algorithm of managing a patient on IV insulin. And so I think trying to make them as successful as possible with leading them with what is to come really helped make us successful in the beginning.
That's good to hear. Jennifer, you had that pilot approach at your organization. What would you pivot and why?
Looking back on it, we allowed for insulin to be ordered without EndoTool insulin drips. We kept 2 different processes in place, and that did lead to issues. And I think we might want to do that differently if we had it to do over again. We did have some instances where prescribers were challenged to find the order set that they needed. And so we've since remedied that, but that was an issue that we worked through. We would have also been more deliberate, I believe, with prescriber education for EndoTool. Although we had a training module available, housewide communications, grand rounds presentation, it's still a challenge to get to everyone, especially when you have a mix of residents and interns, fellows, attendings, and they're all rotating through these places on a monthly basis. It did make it challenging to ensure that all were aware of EndoTool and the value of it. And so I think we probably could have spent more time on that early on, and maybe even work with our interns and some of those, just boots on the ground teammates to get their ideas on how best to reach the masses.
Very insightful. Christy, UPMC had that big bang approach. What would you pivot or change and why?
Yeah, just really taking the baton from Jennifer. I think that looking back, our opportunity was probably some more focused provider education, especially on the transition tools, to get more buy-in and adoption of the recommendation. So one of the things we found was, I think our providers were unprepared for how quickly EndoTool would say, hey, the patient's ready to come off, and they'd be getting that kind of messaging and communication from our nursing team. I think we were used to having patients on insulin drips much longer. So I think showing some of that data and getting more buy-in, and again, because it was Big Bang and we have a lot of residents and different physician groups, I think we had some opportunities there for some more robust physician education, or maybe use of champions within the groups rather than just relying on our endocrinology team. And then for nursing, I think that we did a better job with education, but the one thing that now that we know is that I think our nurses were somewhat unprepared for how EndoTool would recommend supplemental carbs. It's something that they just weren't used to. They were used to treating when someone's blood sugar dropped. They weren't used to, real proactive treating and then recheck. So I think emphasizing that in the training and helping to connect to the why with the hypoglycemic rates before and after, would be something that definitely I think that our nursing team would put more of an emphasis on to help them understand that as well.